or apples? How well can you get a job if you don't have any teeth? Or if your teeth look like in the picture down here, what kind of job are you going to be able to get? Are you going to be CEO of a really good company? Probably not. You're probably going to be working in a low-income paying job, which is going to impact all other aspects of your life as well. In addition to Medicaid adults or Medicaid children potentially having a difficult time accessing care, there's lots of other populations as well. The second picture I have is a patient of mine who has both a physical and an intellectual disability. And again, oftentimes dentists are reluctant to see people with physical or intellectual disabilities in their chair for a variety of reasons. Some may be that they feel like they haven't been adequately trained and they can't provide adequate care for the population. But oftentimes, when you treat somebody who has disabilities, it may take longer to provide the care. And again, the patient may have public assistance, such as Medicaid insurance. And so you're taking longer to actually treat the patient, and you're going to get reimbursed at a lower level. The last group I want to talk about, but certainly not the only groups that have a difficult time accessing dental care, are the elderly. Independent elderly who live out in the community and have good health can usually access dental care. But people who have chronic health problems, who tend to be homebound in their own homes and have a difficult time getting out, and people who live in long-term care facilities or nursing homes often have a very difficult time accessing care. If someone lives in a nursing home, the aides may not have their own good oral health knowledge to know how to adequately take care of the residents in the home. And the people who are in the homes often have had deteriorated health, and they may have arthritis in their hands, and they can no longer brush their teeth well. Or they've lost vision, and they can't see if they're getting all the plaque off their teeth. The good news is that the elderly are keeping their teeth much more than in the past. But the problem is, when they can no longer take care of their teeth, their mouths end up looking like the one that you see there. So, why do we have all these problems? Again, as I talked about, from a government standpoint, there's discrepancies as to whether people believe it's a right or a privilege, dental care. But I think even within dentistry, there's some discrepancies as to whether dentists believe that dental care is a right or a privilege. I work with fourth-year dental students, and we send them out into the community. We send them to community health centers so they can work directly with underserved populations and see what the need is. And there is literature out there that suggests that if students are exposed to working with underserved populations, they learn the skills for how to do it well, they're more likely to treat underserved populations once they graduate. And as a result, the Commission on Dental Accreditation, which is the regulating body for dental schools, has now mandated that all dental schools provide community-based experiences for their dental students. Other people, such as Pete, are looking at the disparities in care, again, whether it's age disparities, racial and ethnicity disparities, etc. And by doing the research and documenting the disparity in care and the lack of access, hopefully policies will be developed to help address that. Lastly, we're looking at alternative models for providing care. For example, some physicians now provide dental fluoride varnish, which helps prevent cavities for children's exams in their appointments. And so when you go for a well-child exam, not only will you have your whole overall health assessed, but physicians are encouraged to look at the children's mouths and place the varnish, which can help prevent cavities. And we're looking at reimbursement mechanisms for that. Also, some states such as Minnesota and Alaska have looked at adding an additional dental team member called a dental therapist. And that is someone who is trained to do simple extractions, simple fillings, and the hope is that they'll go out into the communities where traditionally underserved populations live and will be more likely to provide care to those populations. Lastly, I do want to put a plug in for water fluoridation. Water fluoridation has been shown to reduce the amount of cavities in the population. And in Iowa, we have really good water fluoridation, but even in this past year, the Des Moines Water Works talked about removing fluoride from the water. And so then you're going to be losing the opportunity for everyone, regardless of access to the dentist or the ability to pay for toothpaste, or the ability to go seek dental care. If you take fluoride out of the water, people are losing that preventive method. So if it comes across in a town where you live, please encourage people to keep water fluoridation. Thank you very much.
Can I use Mr. Microphone?
You could do that and walk over here.
I can't turn it on.
So you just hold the bottom, press the bottom, and hold it for a second, and it'll come on.
1, 2.
You're on. You're on.
Hi, I'm Bernard Serofman. I'm with the College of Pharmacy. I want to start with 3 basic ideas. One is that health is a right, not a privilege. That we can stop there if we don't believe that. And I think people in the room will believe that. So that's first. Second, drugs work. Most of the time, but drugs work. And in fact, statistically, half of the people in this room have taken a medication in the last 30 days. And statistically, over the last year, 80% of us have. So drugs are out there. It's kind of interesting. As a profession, we educate students, and I teach them to say, here's this little tablet, put it in your mouth, it'll change your body chemistry, trust me. And you do, because we're good at our job, we understand what we do, and there's a lot of health profession knowledge behind that. But the second thing is that there are risks in taking medication. And that's really important. Statistics say that somewhere between 4 and 10 admissions to hospitals, and I won't pick on any hospitals because it's different for every hospital, but 4 and 10 admissions to every hospital out of 100 are due to mismanagement of medication. A few years ago, and we've kind of fixed that as a healthcare system, about 50% of the people that left a hospital after a myocardial infarction would return to the hospital within 90 days because their medication was mismanaged. So my points today are that people have a right to medication, and they have a right to the information that allows that medication to work well. And I honestly believe that bad healthcare is not a right. It's good healthcare. It's not that we just have it. And so if we look at this for a minute, and the 2 things, access to medication and access to medication information, those are the major things. Access to medication. About 240 billion prescriptions in the United States last year, about 2 years ago. 240, that's quite a lot. Dollars. About 2.5 billion prescriptions. So a lot is going on with prescription medication. And we want to be sure that people are healthy. Now, the statistics vary, but somewhere around 700,000 emergency visits in the United States in that same time frame were due to medication mismanagement. And about 100,000 hospitalizations. Those statistics are really hard to grab onto, of course, but you get the idea that we need the medication and the information. Several years ago, I did a study on medication sharing. And it was interesting. I was wondering what happens when somebody gets a medication. Do they share it with others? And I did the study in an anonymous Midwestern city that has a major university that I happened to be living in at the time. And we studied people for 3 months. And what was really interesting was that in that 3-month period, this was a pilot study that never ended up going anywhere for some other problems, but in a 3-month period, 6% of the medications that were dispensed in that anonymous city were shared with someone else. Got a great story of someone, when we were talking about medication sharing, who said, yeah, I was at a conference like this one, and I started getting these pains in my chest, and the guy next to me who I just met said, well, I know what that is. Here, I have some medication for that. Here, take that. Well, was that pain an upset stomach, reflux, or were they having a heart attack? I don't know, but the guy's medication worked. Because the person was there to tell me the story. And so we have to think about those things in terms of medications and medication knowledge. In our study, we found that the medication would be shared from hand to hand, and we did another medication sharing study a long time ago, and medication could be traded for years, literally. go to people's medication storage units, whatever those are, and you would find things. And they'd remember the medication, but they couldn't quite remember what the information that went with it. Again, that creates a problem. So we try as a profession to be sure that people have access to the medication and access to the right information to use that well. I'll give you 2 examples. And by the way, I should tell you what's going on here. This happens to be one of our pharmacy residents, and this is an Iowa pharmacy, and he's explaining some non-prescription medication to this gentleman. And this other one is a pharmacy student and a member of our adjunct faculty and our leadership board who goes on a mission to Uganda, and you can see the medications there. 2 years ago, I was in Nyamasheke village in Rwanda, which is right on Lake Kivu, right near the Congo border. I walked into an MSH pharmacy drug distribution center there. The center was about as big as this room. There was medication from floor to ceiling. They are funded by PEPFAR and the Gates Foundation. Lots of drugs. But that wasn't my purpose to go into this place. I just happened to pass it as I was going to the clinic where my daughter was working. I got to the clinic, and my daughter showed me the clinic. I said, well, can I see the pharmacy? And we went into the pharmacy. And there were, I'll exaggerate, 10 bottles that had medication in the pharmacy. That was it. And the distance between one to the other was about 100 feet. Maybe 100 yards, but about 100 feet. Because I could walk right out and walk right around the corner, and I was in the other. So you got the distribution out there, but it's not getting to people. So distribution is really important. And what drugs did they have, by the way? It was mostly analgesics and antibiotics. And that's basically what they could have. And they would just hand them to the people, just kind of dump them off and say, gee, take these. So we have a long way to go in the world to get good drug distribution. Second one happens to be a little closer to home. I have been working with the Iowa Department of Corrections and looking at medication for offenders once they leave the system. And by the way, for you students here, the record system that they keep to manage the offenders is called ICON. And they refer to all of their facilities as campuses. So I felt like it was pretty easy to understand the system. When a prisoner leaves, and the prison system started this about the time I started working with them, they would get 30 days worth of medication as they left. And that was it. We know that it takes at least 90 days to hook up with the healthcare system, and especially individuals who have been out of society have a lot of trouble hooking up with the system. So we set up a system where they could get 30 days, and then they could get a voucher. The vouchers, in this context, the voucher system works, which is an authorization for 60 more days or 90 days worth of medication to help them connect. Now what's important about this is the access, but it's also the information. Somewhere around 40 to 45% of all the people that are in prison right now have behavioral health or mental health diagnoses. Some of those people have very serious diagnoses, and when they leave and you take their medication away for 90 days, all of a sudden everything that allowed them to be controlled within their disease chemically has gone away. And it could be years that they have been on it for their, we could call it bipolar or manic depression, or for their schizophrenia or whatever it could be there. And we take that medication away and say, goodbye, you're out. And so we've started working on the idea that we can educate them that they have to keep that medication in so that they don't end up doing something that causes them to return to prison. And just to let you know, we have a pilot project in Polk County and we have one in the state. And it looks like people who are not in our pilot system are returning back to prison threefold faster than those who get into the system and get the medication for 90 days. So we have to educate them to get their medication, but we also have to give them their medication. So that's my 2 points. Access to the drugs, but access to the information. Thank you.
Hello, my name's Eric Tate, and I teach geography. So I'm a former engineer. This is a good spot to be on this panel. And I'm actually encouraged by, Greg, your comments about greater infusion of social dimensions into the curriculum these days. And it certainly wasn't the case when I was taking engineering classes 25 years ago, okay? So I actually worked as a civil engineer, primarily doing water modeling. So for, say for instance, natural hazards like floods, I might look into things like modeling the flow of water, or maybe I could work as a transportation engineer trying to model the impacts or the best evacuation routes, okay? Or I might design levee systems to protect communities against extreme river flows. All these came into play in Hurricane Katrina, right? From a science perspective, we had a pretty decent understanding of the storm. I mean, it was one of the most massive storms that crossed the Gulf. We knew the forecast ahead of time. We had a good understanding of the storm surges. We had spent billions and decades on levee systems and pumps in New Orleans, and yet it was a spectacular failure. And for me, what comes to mind when I'm thinking about Katrina was none of this stuff actually. It was the images of people taking axes and trying to break through their roofs so they can survive. It was elderly people sitting in a wheelchair stuck on a bridge for days at a time. It was people that were stuck in the Superdome for days at a time without food and water. How can this happen in one of the most technologically advanced nations on our planet? And I think one of the main problem is that with our science and technology, we don't take a sufficiently human-centric approach, okay? So we've heard some talk on this panel already about kind of disparities, okay? So in my work, I do modeling and social vulnerability. So looking at what are ways, or how does it happen that certain groups in our society become more susceptible to disaster impacts than others? Taking a human-centric approach actually makes, even if you're looking at the same aspects, makes you ask different questions. Okay, so if I'm looking at building a levee, okay, we're actually debating. We just debated one here in Iowa City that we're building southern part of the Iowa River through the city. We might look at things about what's the cost-benefit analysis from an economic perspective. We might even think from a human-centric perspective. How many people are going to be protected by this new levee system, okay? But I think what it demands of a true human-centric approach is we look a little bit deeper, okay? Not just how many people are affected, but who is affected, okay? Who is protected, who is not protected by this new system, okay? If we are designing an evacuation system to evacuate a city, who's going to be able to take advantage of that? Who's going to be left behind? If we're designing a system for post-disaster assistance, and we decide that, well, the pillars of our community are the business sector and homeowners, who's not being included in this kind of system, okay? Where are we going to get that perspective added? I would certainly submit in our political climate, putting more legislation into effect that we need to account for human disparities in our policies. It's not likely to gain a lot of traction. So certainly an alternative path is to ingrain some of these ideas in our educational system as we're coming up. That these decisions about science and technology are not just about engineering efficiency, economic viability, but some sort of these human-centric dimensions. So it's not just about disasters, it's many of our decisions. This starts to come into play when you start thinking about environmental justice. And what we start to realize is that a lot of the challenges we have are kind of a result of power differentials. And so if we're looking at air pollution in Chicago, or a new incinerator, or oil refinery in California, whether we're talking about building a new hydroelectric dam that's going to displace thousands or perhaps millions of people in the case of China, if we're building a new mine, and who's going to be impacted by the dangers and the pollution from that aspect. So what I'm calling for, I think, is a broader examination of human-centric approach. You take a look at sustainability. We may have all seen these 3 spheres of sustainability, right? There's people, society, and environment, okay? I think most of us could have a pretty good understanding of what maybe economic sustainability is, maybe what environmental sustainability. Please tell me what social sustainability means. How are we going to ingrain that into our decision-making in science? Okay? These are some of the questions we need to think about. And then one step further, what are the constraints faced by people when you have these types of disparities? That's all I have.
Yeah, the overboard. There you go.
Okay, thank you so much. Well, thank you. Of course, Peter and Michelle and Bernard all hit on my primary point, which is, of course, that healthcare is a human right, not a privilege. And I want to talk a little bit about that in terms of sort of the history of that, and you may be familiar with the report that's shown on the slide. And then talk about one of the primary ways that in healthcare and in medicine that we are trying to address this whole idea of healthcare disparities. So just as introduction, again, believe that all people should have the opportunity to reach their full potential for health. Again, all right, certainly something that should be there for everyone and a privilege, and I'll be interested during our discussion. I was kind of struck by Michelle's comment about dentists in terms of having some differences in terms of some people seeing it as a privilege and some as a right, so hopefully we'll have a chance to talk about that. And those who live and work in low SES circumstances, and often this is disproportionately represented by individuals from certain racial and ethnic backgrounds, often do not have that access to health care. Many of the things that many of us take for granted who are from different privileged backgrounds, that we just don't think about. If we have to go to the doctor or the dentist, we go, because we have that kind of privilege. The IOM, the Institute of Medicine, in 2002 released this really groundbreaking report, Unequal Treatment, which highlighted the disparity and the disparate treatment that individuals from certain racial and ethnic minority groups received in terms of care. And it really sort of shifted, in many ways, the ways that healthcare providers